All right, welcome everybody to tonight's webinar hosted by med school tutors on ARDS and mechanical ventilation. My name is Dr. Joe Hanson, and I'm going to lead you through with Dr. Majid. And to start us off while everybody's kind of sitting down and getting comfortable, I'll introduce us and let you know who we are so we're not totally random people shouting advice to you over the internet about how to answer these questions on the USMLE. So again, my name is Dr. Joe Hanson. I've been working with med school tutors as a board exam tutor for about 4 years, and in that time frame, I've tutored a couple hundred students for everything from basic biochemistry up through step 2 CK. I've spent 5,000 hours or more online tutoring students over camera like this. I'm pretty familiar with the material that's going to show up on these exams, and hopefully I can kind of deploy that knowledge tonight for you guys to kind of help you to learn how best to answer USMLE questions when it comes to mechanical ventilation and acute respiratory distress syndrome. Sana, you want to go ahead and introduce yourself?
Yes, perfect. Thank you so much. So my name is Sana. I am a resident at Brigham and Women's Hospital at PGY2 in radiology. I have also been with med school tutors for about 4 years now. Have tutored many students all across the spread of exams and over the course of time. And we're very excited to impart some of the things that we've learned over the course of studying and teaching, and tips on how to help you guys do well on ventilation related questions.
All right, without further ado, I'll go ahead and just tell you a little bit more about Med School Tutors and who we are as a company before we move on. Med School Tutors is a one-to-one online tutoring company. We do everything from pre-med, applying to medical school, which most of you have likely already gotten through, so don't have to worry about that, up through board exam preparation and even residency applications, and then board exams beyond into residency step 3 and beyond. We've been working as a company for over 15 years and worked with hundreds and thousands of students at this point. And we have tons of medical students, residents, and some attendings who work on our staff who have all done an excellent job on their board exams and have gotten into very prestigious residency programs. And we all love to teach, and we all love to work with medical students, residents, and anybody interested in medicine. So if you guys are interested in working with us, please feel free to reach out. You'll see our contact information on the bottom of the screen. So more about what we're going to be doing this evening. We're going to be talking mainly about mechanical ventilation, why we do it, how we do it, what we're looking for when we do it. We're going to be talking about arterial blood gas analysis, because this is the main way we're assessing how mechanical ventilation is working and whether we need to continue utilizing it. And then we're going to end by talking about a specific diagnosis, acute respiratory distress syndrome, which comes up pretty frequently on the step 2 CK exam, both to diagnose it and then to talk about how we would try to manage it as best as we can. Also, we'll be doing a live question and answer at the end of our talk this evening. If there's anything that's confusing, you guys can please feel free to send us questions via the chat interface in Zoom here. Go ahead and send questions to us during the conversation as well. We're going to be asking you guys to interact as much as possible. So you guys can bear with me asking you guys questions. If you can type responses to us, it's definitely helpful to try to get some kind of interaction flowing here as we run through some of this very detailed material, make sure everybody's still on board. So don't hesitate. You guys should have received a message in the chat box just a moment ago asking about a survey that we'll ask you to fill out at the end. Feel free to type right back into that if you have any questions that we can answer if anything's not totally clear as we're talking through this stuff. So Sana, why don't you take us through just a basic definition of terms when we're talking about like respiratory physiology?
Perfect. So this is a diagram that may be familiar to many of you who have done a little bit of studying on this in the past. But I think it's really important to sort of set yourself up with a framework of what the sort of classic definitions are, what we're working with in normal respiratory physiology before we even think about ventilation. And so there are 3 key terms that we've outlined here. And if you guys know what they already are referring to, what sort of the definitions of them are, please feel free to throw them into the chat. But the first is this TV. And I'll give you that one right off the bat. So that we're looking at tidal volume. So tidal volume is typically looking at, if you look at this graph, you can see this sort of undulation of the curve up and down, these first 4 sort of sinusoidal waves. That is describing tidal volume from the peak to the trough of that first sort of set. And what that is describing is your normal breathing pattern, right? So you and I just standing around, breathing your normally up and down. This has to do with your normal breathing pattern. And this is your tidal volume, the amount of air that you're moving in that time period. And then we also have a couple of other sort of parameters. So the biggest breath you can take in, the biggest breath you can take out. So the second term that we have listed here is called functional residual capacity. Okay, so functional residual capacity, if you look on this diagram, you'll see this sort of bottom square on the left portion of this graph underneath the tidal volume. And so what that means is how much air is left in your lungs at the end of a normal breath, right? So as we're just breathing normally, how much air do I still have inside my lungs that I'm not moving very freely? So that's functional residual. And then there's vital capacity, right? So vital capacity is now looking at the very, very last portion of this graph, right? So we're looking at the green bar, so up to the highest level, and then down to a little bit above the level of the base. So the vital capacity is basically the entirety of the breath you can take in, so the deepest possible breath you can take in, the biggest inspiration, all of that volume except for the volume that you're not moving. So there's always some amount of air. So you breathe out all the air that you can breathe in your lungs. You completely exhale. All what's left in your lungs after that exhale is called the residual volume, right? That's that RV bar across the bottom. And then if you were to then take the biggest breath in, that would give you the vital capacity, right? So it's that sort of difference between the entire volume and that bit that's left over in the lungs after a complete exhale. And so these are the key features that we're going to be thinking about when we think about ventilation and what is going on in our lungs. But those are sort of the main volumes you should be thinking about. Anything I missed on that, Joe? Anything you want to add?
No, you nailed it. Thanks for walking us through that. Also to our audience, I'll apologize if it looks like we might be distracted from time to time glancing off to the side. I'll be responding to your questions in text as well. If you guys send stuff to us, we can type it out to you or maybe elaborate a little bit more further as we're talking through stuff on here. So if from time to time as Sana's talking, I'm looking off to the side, I'm just trying to answer some of the questions your colleagues have. So I apologize for being a little bit rude there. So kind of progressing from what Sana had mentioned there about, taking a deep breath and getting our forced vital capacity out of that measure, I want everybody to try to attempt to take a deep breath right now and kind of, do this little exercise if you've never done this before. But if you fill your lungs entirely and then you just relax, you don't forcefully exhale, you just stop doing anything, the air just kind of leaves. You didn't have to actually force the air out. Now, the reason that happens is because our lung has compliance and elasticity. I want you to imagine your lungs like a big party balloon. And if you fill a party balloon with air and then you let go of the party balloon, it will deflate and fly around the room as the elastic material of the balloon contracts back to its original size. That's what your lungs are doing all the time when you take a tidal breath and when you take a bigger than tidal breath. Every time you take a tidal breath, or if you take a big breath, when you relax, you land back at your functional residual capacity. But notice, even after relaxing, I'm still able to speak. And in fact, I can even push more air out. So the question would be, why did I have the capacity to continue blowing air out? And then when I relax, why did I breathe in back to my FRC without having to exert any force? And the answer is that it's not just our lungs. If it were just up to our lungs, we would collapse down to zero volume every time we relax, and that would be really difficult to deal with. But our lungs are in equilibrium with our chest wall. There is a small space between our chest wall and our lungs, which is going to be the pleural space. There's really nothing in there, apart from some pleural fluid maybe, to kind of allow for a little bit more lubrication between the two things. But if the lungs collapse, the chest wall has to follow. And if the chest wall expands, the lungs have to follow because there's nothing between them, and nature abhors a vacuum. So if you lower your diaphragm and expand the size of your chest, your lungs have no choice but to expand, lowering the pressure inside your lungs and forcing atmospheric pressure air into your lungs. The point that I'm getting at here is that if we take a deep breath and then we relax, then air just leaves. So using that principle, I'm gonna have you guys type into the chat box now. Can you guys tell me, if we have a mechanical ventilator, somebody who's intubated with the machine breathing for them, is the machine doing the majority of its work while they're breathing in or while they're breathing out? So go ahead and type into the chat box, let me know. In or out, inhalation, exhalation. When is the machine actually doing work? Okay, I'm getting a couple of different answers here. I'm almost 50-50
pretty good
right
spread.
now.
Yeah.
Okay, well, I'd say we're closer to 70-30 now, just about. So give you guys a couple more seconds. Okay, so thanks everybody for playing along with the game here. I think I got about like 70-30, quite a few answers, so thanks for answering. 70-30, most people saying inhalation, and that would be correct. The machine pushes air into the person, and then the machine doesn't do anything, and the comatose patient just naturally exhales the air because we don't have to consciously think about our lungs elastically recoiling back to their more desirable state, which is a smaller state. So the point of this diagram, which those of you who have taken step one probably have forgotten about by now, and those of you who are thinking about taking step one probably don't like very much, is that our thorax and our lung want two different things. And what this graph is showing me is that the thorax wants to pull with negative pressure to open everything up. The chest wall wants to expand naturally, and the lungs want to collapse, which would create positive pressure, which means breathing out. So the lungs want to collapse, the chest wall wants to expand, and the point at which they have reached equilibrium is going to be the FRC. That's the point at which there's no movement of air in or out until you exert some force by lowering the diaphragm or pushing the diaphragm up to either forcefully exhale or forcefully inhale. So, bonus question related to this then. If I were to have a person who had loss of elastic tissue in their lungs, somebody who had destroyed a lot of their lung parenchyma, somebody who had emphysema, can anybody tell me in the chat, would we have an FRC that would increase or decrease in somebody who has COPD emphysema? Okay, getting a little bit closer to like 80-20 in these answers. Keep them coming in. All right, so thanks for playing along, guys. I'm seeing a few saying decrease. I'm seeing a lot more saying increase. Think about it like this. If the lung loses its connective tissue, it is a stretchier balloon. It has less capacity to collapse back down to its original size. If the lung's super floppy, and that's the problem that we have in COPD emphysema, then that means the lung isn't fighting the chest wall as much, and we get to expand a little bit more. The chest wall wins the argument a little bit more because we've lost the capacity of the lung to collapse. So as a result, somebody who has COPD emphysema, you might recognize this, has hyperinflated lungs and a gigantic anterior-posterior diameter on a chest x-ray and a flattened diaphragm because they have hyperinflation of their lungs at all times because their lungs are floppy, not really able to collapse the way they should. The takeaway we can pull from that then is that we actually want our lungs to collapse. That's actually kind of a good thing for them to pull back down to their smaller volume because that helps us to exhale and maintain normal homeostasis with our breathing. Now, the final thing to mention here is the idea of compliance. Compliance is stretchiness, and the actual definition of compliance is the change in volume that you get for a given change in pressure. Now, in plain English, that means stretchiness. And so somebody who has greater compliance has COPD emphysema, stretchier lungs. And somebody who has restrictive lung disease like pulmonary fibrosis, not as much compliance, far less stretchy lungs, smaller lung volumes. The final little thing to take away from this then is that compliance really doesn't want to go either direction. You have lung disease no matter what you do to compliance, so it's best if we just don't mess with it and don't change it. All right, anything to add to that, Sana, before we move on here?
No, that was excellent. Thank you for that review.
Oh, yeah, of course. All right, well, thank you for taking us through our first practice question here.
All right, let's do it. Okay, so the way that I generally like to go through these questions is I'm going to take it sort of line by line and walk all of you through my thought process. Having said that, I would love if you guys are racing ahead and raring to go, then please feel free to throw your answers out there. Let me know what you're thinking, put them into the chat as we're going, but I'll sort of start to walk through my process. So 7-year-old boy is brought to the ED with 2 days of rhinorrhea, congestion, cough, and wheezing, started this afternoon. Okay, so I'm already thinking what sort of respiratory diseases take place in children. He's having some sort of URI symptoms for 2 days. So hard to say, but it seems like it got suddenly worse today. So first things in my mind. Received nebulized albuterol and ipratropium, IV steroids, and IV magnesium sulfate. Okay, so based on all of this, this is already sort of telling me that the team is thinking about an asthma exacerbation, right? They're thinking about, that's why they're giving him all of these sort of duonebs, steroids, etc. Okay. Symptoms do not improve, and patient is admitted to the ICU. Started on continuous nebulized albuterol and IV terbutaline. Okay, so basically they're describing a deteriorating picture, so continuing to get worse. Bilevel positive airway pressure, also known as BiPAP, it started on hospital day 2. After 2 hours of therapy, pulse ox is 89 on 60% FiO2. So 60% FiO2 is quite high. So now we're looking at getting to the point of extremely high levels of FiO2, still pretty low oxygen levels, patients becoming agitated, diminished air entry on chest auscultation. So this is, I think, a very key and important finding here, is you're not really hearing breath sounds. And in any sort of asthma patient, that should immediately trigger you to think their airways are extremely, extremely tight. So I'm already very concerned about this breathing. No wheezing is heard. So again, classically people say, oh, wheezing is very concerning for, asthma, but if the airway is extremely tight, you may not hear wheezes at all. Then ABG results, 722, okay, so I'm very concerned about this patient's blood gas already. PaO2 is 50 and PaCO2 is 62. Okay, so now we're looking at a hypercarbic picture. And so we have, now they're asking us what's the best next step in management. So looking at the overall picture here, we see patient in clear respiratory distress. They've already tried nebulized sort of treatments, continuous nebulizers. They've tried BiPAP. Everything keeps getting worse and worse. ABG still looks pretty crappy. So now the question is, where do we go from here? So based on this alone, a lot of people are putting in the correct answer already. I love it. So everyone is getting the same sort of sense of this that I hope I'm conveying, is that I'm very, very concerned about this patient, right? And so BiPAP with close observation is no longer appropriate at this time. We've tried it. It's not working. Oxygen levels are still bad. And CO2 levels are still high. Intubation, we'll come back to. Racemic epi, not really appropriate in this. Again, we've given him already nebulized nebulized duonebs, nebulized sort of continuous albuterol, not really doing anything. Needle thoracostomy, that's for like a pneumothorax. There's no real reason for me to be thinking about that right now. And tracheostomy. Tracheostomy is a more permanent solution, right? You don't do tracheostomy unless someone's already been intubated and is being unable to be weaned from ventilation. So that brings us to B, right? So when all else fails, when you've tried everything else and you cannot get control of this patient's respiratory, hypercarbic pattern, especially in this low O2 setting, you have to control it mechanically. And so the correct answer in this case is, in fact, endotracheal intubation for this patient. Anything else you would add to that sort of thought process, Joe?
Thought process was perfect. Only thing I'll add to this question is just to say that endotracheal intubation would be the thing that we would do in order to mechanically ventilate the patient, in order to make sure that we protect the patient's airway while we're pushing air into their chest, is to intubate them, usually with oral intubation. We could use a tracheostomy, but that would require us to actually do the procedure of placing a trach, which is a little bit more complicated and time consuming, certainly not usable in an emergency situation. The one other thing I want to mention that we're going to utilize as we move ahead here is that the pH assessment and the PaCO2 assessment are important parts of the ABG that we should always be paying attention to when they give it to us. And the simple thing that I want to put in right now for how you will answer questions on the USMLE exams is to say that there's one good value for each of these different measurements. For the pH, 7.4 is your go-to. If you're anywhere above or below 7.40, the question is kind of leading you in a direction. Now 7.38, 7.42, maybe really not that serious, but anything that's moving away from 7.40 is probably giving you some information in the context of the question. Similarly for CO2, 40 millimeters of mercury is your staple number. Yes, there's a normal range between like 35 and 45 for PaCO2, depending on which resource you look at. There's slightly different ranges where it can be normal. But if you have a value that's over 40, in this case 62, quite high, but anything over 40 really is going to represent that we have a little bit more CO2 than normal in our body. So keep that in mind as we move forward to a couple more practice questions that we'll do later on. Really important to remember that we have very straightforward numbers that we're looking for here. We don't really have to get too complicated with our assessment of, looking at the regular lab values there. Sana, that's one reason why we would intubate somebody if they were in respiratory failure and they were hypercapnic, but what are some other reasons that we might use mechanical ventilation and intubation?
Yeah, definitely. So there are a number of reasons that this makes sense. And a lot of you may have heard this in the case of trauma settings, in the case of, people with neurologic conditions, in the case of people who are septic. There are a number of reasons that mechanical ventilation could be indicated. The primary is, of course, respiratory failure, right? So that's number one. And that can be hypoxemic or hypercapnic respiratory failure. So in the example we just gave you, the patient was hypoxic as well, but the hypercapnic respiratory failure is extremely important because sometimes that can be overlooked. People see the oxygen levels and say, oh, well, the oxygen levels are okay. But sometimes that hypercapnic drive is what's really causing the oxygen levels, causing the increased breathing, and you worry about patients tiring out and able to continue that certain level of oxygenation in spite of that increased effort. So respiratory failure, of course, hemodynamic compromise as well. If people are on, I have very rarely seen a patient on pressors who is not also intubated, and so all of the sort of gambit in terms of shock, right? You think about distributive, septic, neurogenic, all of those sort of the hemorrhagic, et cetera, the types of shock. That is another very important indication to consider. Okay, am I worried about this patient's airway at all? Is there any concern that they may not be able to protect their airway? And that can happen in the case of hemodynamic compromise. And then elevated ICP, I think that neurology and neurosurgery probably sees this more than most. But in the case of patients with, some sort of brain mass, any reason that they may have an elevated intracranial pressure, there is an increased risk of herniation. And so in that case, intubation is used to sort of control that and mitigate that risk as well. So again, big thing is respiratory failure, but almost always in hemodynamically compromised patients, particularly if they're very sick, but there are also a few additional situations in which it can be useful.
Awesome. Thanks for running through those. I think the mnemonic that I've seen most commonly used, at least from the neurosurgery perspective, is GCS of 8, you need to intubate. So I'll point out, you don't need to know how to calculate a GCS score on the step exams. And I know this very personally because I walked into my first ICU rotation on day 1 of MS4 and they told me to calculate a Glasgow Coma Scale score and I had no idea, even though I did pretty well in step 2. So you don't need to know it for that, but you do need to know it clinically, especially if you're working in the ICU with patients who are intubated. But if the GCS is 8, that's given to you in the question, they probably can't protect their airway. And in many cases, we're probably worried about elevated intracranial pressure anyway. So 2 good reasons to intubate in that case. Really good question asked by a student here. How do we interpret the PaO2 value? Since I mentioned, here's the value looking for pH, here's the value looking for CO2. What about PaO2? Well, that's a little bit more complicated. So the oxygen levels obviously vary quite a lot in patients, which you know from your own experience, having seen questions or patients where oxygen saturation's 92% in this patient, 96% in this patient. Well, saturation correlates with the PaO2 value, even if they're not exactly the same. And so what that means is that there's a variety of numbers that we might be okay with when it comes to PaO2. But the general rule of thumb that I would kind of stick to is that if somebody has a PaO2 value that's falling lower than 70 on the exam, so 70 millimeters of mercury, the normal value being 100 in a healthy normal individual, if it falls below 70, we start to kick in what's called our hypoxic drive. So what I want to emphasize here is that all of us have a respiratory driver that's telling our medulla how fast we should be breathing. And before I mentioned it, you guys were all probably breathing autonomously. Now you're probably all thinking about breathing at this point, so I'm sorry about that. But before that, you were breathing at a certain rate based on the CO2 level in your blood. Everybody at baseline is operating on what's called a hypercapnic drive. We keep CO2 exactly at 40. If it goes a little bit above 40, we start to hypoventilate a little bit to bring us down. If we breathe a little too fast and the CO2 goes down, our brainstem tells us to stop breathing so much so we can pop right back up to 40. 40 is the number that we're seeking for PaCO2. And so as a result, we're going to be like laser focused on that. But what if our oxygen levels drop despite the fact that our CO2 is okay? If that happens, now we're going to start breathing faster for oxygen. We're not very good at that. The hypoxic drive doesn't really improve our oxygen very well. Imagine yourself going up to the top of a tall mountain where the environmental oxygen is like 60 millimeters of mercury. You'll breathe very fast because you're hypoxic, but you won't really fix your oxygen level as a result. So our hypoxic drive is another way that we'll breathe fast. But the reason I'm bringing up our respiratory drivers is because CO2 and O2 are the 2 things we're paying attention to when we intubate a patient. And when they give you a question on mechanical ventilation and they say, what do you want to do? How do you fix this patient who's being intubated, mechanically ventilated? In the vast majority of cases, they're going to be asking you, should I be fixing the oxygen? Yes or no? Should I be fixing the carbon dioxide? Yes or no? And how would I fix the carbon dioxide or the oxygen in this patient? And so if the CO2 value is not 40, you probably want to fix it. If the oxygen value is below 70, that's probably where you need to start making an intervention for that patient. For reference, somewhere around 60 millimeters of mercury is roughly around like an 88% oxygen saturation. And that's the number clinically that we really hate to go below, is around like 88, 89% in that territory. So when the oxygen falls below 70 into the 60s or below that, that's where we're going to want to intervene. And that comes to, how do we intervene? Now, for oxygen, the first answer is super easy. Just give them more oxygen. So the fraction of inspired oxygen, super straightforward answer, just give them some more of that. That should improve their oxygenation in the vast majority of cases. The other way that we can fix oxygen is called PEEP, or positive end expiratory pressure. I'm going to set that one aside for a second. We'll come back to defining what that means in a moment. And for carbon dioxide, the real thing that matters for CO2 is simply the respiratory rate and the tidal volume. Together, these two values roughly equate to what's called the minute ventilation. Minute ventilation is like the cardiac output, but for your lungs. So heart rate times stroke volume is how much blood your heart's pumping out. Respiratory rate times tidal volume is how much air your lungs are moving around, essentially. And because CO2 is not a diffusion limited gas in the way that oxygen is, I really don't care what's happening to the lungs. As long as I'm moving air, I'm probably breathing out CO2 in many cases. And so there's a direct correlation, an inverse relationship. The more you're breathing, the less CO2 we'll have. And so that means if you want your patient to have less CO2, you increase their respiratory rate or you increase their tidal volume. If you want them to have more CO2, you decrease their respiratory rate or you decrease their tidal volume. So CO2 is a little bit more tricky than oxygen insofar as it can be high or low and you want to fix it. Oxygen generally just goes low and then you bring it back up. But these are the only 4 variables that you're ever really going to choose in answers about mechanical ventilation. And you're going to see repetitive questions in UWorld, on MBME practice tests, and on the real exam that just keep asking the same thing over and over again. So when we start equipping ourselves with the knowledge that we can only really answer these 4 things for a mechanical ventilation question, they become a lot easier to understand. Anything to add to that, Sana?
No, that's perfect. And I really love the way you outline sort of the differences. And this should be like an algorithm for all of you. You should look at, when you see a mechanically ventilated patient and they're asking, what do we do now? It's always going to be, okay, which one's wrong? And then if so, one of these things is going to already be optimized and one of them's not. And so just working your way down that algorithm is going to answer 99% of the questions you're going to see.
Awesome. All right. I'm going to hand it over to you to define what PEEP is then. So what is
Perfect.
positive end expiratory pressure?
Yes. So PEEP is one of the buzzwords in pulmonary and critical care. And so the idea here is the best way I like to think about this is thinking about that sort of deflated balloon analogy that Joe gave us earlier. And that a balloon by itself, there's nothing holding it sort of taut. And so the initial pressure to sort of pop it open a little bit is actually quite high. The sort of activation energy to get that initial sort of volume added is the highest compared to continuing to expand once there's already some level of oxygen propping it open. And the same principle applies to your alveoli. So if your alveoli have no positive end expiratory pressure, what that means is that they almost collapse on themselves, right? And the whole point of end expiratory pressure is that at the end of expiration, right? So all of the air, or most of the air has left your lungs, and so there's not as much to prop it open. It's important to provide some level of end expiratory pressure, so some pressure from the mechanical ventilator to allow the alveoli to still remain popped open. And so that's what we're talking about when we're talking about PEEP. When the oxygen is sort of returned during the exhalation phase, do we still have some level of pressure that keeps the alveoli open? And so PEEP, the important things to know about PEEP is that there's a direct relationship. As you can see on this graph, there is a very linear correlation between the amount of PEEP that is provided, so 0, 5, 10, et cetera. You can see a clear increase in the diameter of the alveoli with the more PEEP you give, which makes sense, right? If I'm giving a little more pressure, the alveoli will pop open a little bit more linearly up to a certain point. So once we get to a certain point of PEEP, so you see on this slide, we have 15 of PEEP here, right? Once we get to a certain point, they can only expand so far, right? The balloon's not going to continue expanding forever. There's a point at which the tension is then held within sort of the the wall of the balloon, the wall of the alveoli, with the more PEEP that you give. And it is no longer creating an increased expansion. It's just being held, the tension is just being held in the wall. So the PEEP can continue to rise, but the diameter after a certain point will not continue to rise. So that's sort of thinking about that linear relationship initially, and also what the benefits of PEEP are. And primarily it's to give you that initial popping open to make it easier to inhale every subsequent time.
Awesome. All right. I like that we're sticking with the balloon analogy. That makes it easy for me if I was just imagining something easy to think about. So
Yeah.
I'll simply point out that the thing that Sana's describing here, when you start to apply too much PEEP, is that we develop barotrauma. That's like the buzzword that they like to throw out there for supplying too much pressure when we're using positive pressure ventilation. And then the only other thing I'll throw into here as well is that we had mentioned before, and a couple of the students had messaged us to mention, so good job on the people who did, that the machine, the mechanical ventilator, is typically only working during inhalation. We're pushing air into the person. But not if we're using PEEP. If we're using PEEP, the machine is always on. The thing is that when we're breathing air in, the machine is pushing really hard to push air in. And then when we start to exhale, the machine is just slightly putting some back pressure on our lungs to keep the lungs popped open, or the alveoli rather, popped open like this. So in truth, we were simplifying a little bit when we said the machine only does work during inhalation. For patients that are using PEEP, which is the majority of them, the machine is working full time, but the majority of its effort is going to be during inhalation.
Yeah.
All right, so let's go ahead and use this newfound knowledge to take a look at another practice question that I'll go ahead and lead us through. So this is a next best step in management question. And they're asking us, a 76-year-old nursing home resident is hospitalized with confusion, fever, decreased oral intake. Pretty typical for a nursing home resident. His past medical history is significant for type 2 diabetes, hypertension, osteoarthritis, and gout, and blood cultures are now positive for E. coli. So given the background of confusion, fever, decreased oral intake, it sounds like we have a patient who's developing a bloodborne infection, sepsis, with E. coli. I haven't seen his vital signs, but I can presume he's septic given his clinical presentation of confusion. Despite antibiotic therapy, he slips into respiratory failure. He is intubated and placed in mechanical ventilation with an FiO2 of 70%, a tidal volume of 370 mils, and a respiratory rate of 8, which is something that we might raise our eyebrows at. His current arterial blood gases show the following. And so before we answer the actual question, I'd like to know what of these values is the one that is least good to you guys? Which value is the one that I probably want to change in this case to make better?
Nice.
All right, a few answers coming in. Keep in mind, I'm asking specifically about the ABG findings, not what I'm going to change, but like which of these values I want to manipulate, not how I would do it, but what I want to change.
Perfect.
All right, good. So lots of good answers here. Thanks, guys. The majority of you guys saying PCO2. So of the 4 values that I have in the ABG here, yes, the pH is just below 7.4. And yeah, the oxygen is at 100. But remember, we said oxygen going lower than like 70 or 60 is where we get really scared. But we said CO2 should be around 40. And we're 10 points off of 40 in this case. We have too much CO2. And so when they ask us what the next step in management of this patient is, it's probably to fix the CO2. So what do you guys think our best answer would be? What could we do to fix the CO2 value here? All right, good. I'm seeing 2 predominant answers pop up here with a little bit of dissent with a second answer here. So I'll point out that there are 2 answers that are feasible and possible. So if you had answered either A or B, good job. We've been doing a good job of listening to what we said so far. Insofar as CO2 can only be changed by changing the minute ventilation, which is an equation that is respiratory rate times tidal volume. Technically, both of these things are viable to change in order to change the CO2 value by increasing either tidal volume or respiratory rate, or increasing minute ventilation, blowing off more CO2, bringing down the CO2 value back down to 40 where we want to be. Now there's 2 ways to think about why we are going to choose the best answer. And the best answer in this case is going to be B. So great job to everybody who chose B. The reason being, obviously, I kind of didn't like that respiratory rate when we saw it. Respiratory rate of 8 is pretty low. 12 is a pretty good default number. Anything lower than that, you might start to think, that's kind of a low number. Why did we do that? But the other thing I want to point out is that the tidal volume number is not usually one that we're very happy to change. The tidal volume is usually initially chosen on the basis of the patient's size. So we'll usually take 8 milliliters for every kilogram of the patient's ideal body weight, which is a bit complicated. It's not their real body weight, but what they should weigh based on their height. So it makes me wonder why we didn't just base it on height in the first place. But we're going to look at their ideal body weight and multiply that by 8 to get our tidal volume, which is usually somewhere around 400 mils, maybe up to 500 mils in a relatively large person. Mm-hmm. The problem we're going to run into with tidal volume is that a patient only has lungs of a certain size. And if you try to inflate those lungs more than they should be inflated by giving them bigger breaths at larger tidal volume, it's similar to trying to blow up a party balloon with too much air. You're going to pop their lungs. You're going to give them barotrauma by rupturing alveoli by overinflating them. So even though we said previously that the ways that you change CO2 predominantly are going to be by changing respiratory rate or tidal volume, those are your two good options for CO2, turns out you really only have one, and that's respiratory rate. I personally have never seen a practice question where tidal volume is the correct answer, even in ridiculous circumstances. There's a couple NBME questions that say the tidal volume is 1,000, and they still don't choose tidal volume as the good answer to change, which just blows my mind. They really don't want you to choose tidal volume on these exams. So respiratory rate controls our CO2. We have a bad CO2 in this case. Choose manipulation of the respiratory rate. Anything to add to that one, Sana?
No, I love it.
Cool. All right, let's go ahead and move on to another one then. You're up.
All right, perfect. Okay, so same idea. If anyone has answers already, go for it. So we have a 44-year-old man involved in a serious motor vehicle accident, admitted to the ICU with multiple fractures and internal bleeding. Okay, so trauma case, placed on mechanical ventilation. Over the next 2 days, his oxygen saturation drops below 90%, requiring gradual increases in FiO2. On day 3 of his admission, chest x-ray, which was initially clear, shows bilateral fluffy infiltrates. Okay, so bilateral fluffy infiltrates, speaking as a radiologist, I'm already thinking about ARDS, right? I'm thinking about sort of a diffuse process. So here we have no prior medical problems, no medications, okay. Labs, hemoglobin is fine, platelets are stable, leukocytes 13.5, okay, maybe a little bit high, but nothing crazy. Sputum is negative. Ventilator settings. So we have FiO2 of 90%, tidal volume of 400, respiratory rate of 12, PEEP of 5. Oxygenation continues to drop below 90%. So as I'm looking at this, I'm going to follow the exact same algorithm that Joe was following in his last one, right? So first, what am I trying to fix? Here, they actually don't give me a PaCO2, PaO2, they straight up tell me that the oxygenation is low. So this is actually easier. I'm telling you right now, we're trying to fix the oxygenation. So that puts me down a certain pathway in this algorithm, right? So the carbon dioxide pathway was the tidal volume respiratory rate. So I'm not worried about that. The oxygenation pathway, there are 2 things that I can change. Does anyone remember what those 2 things are before I release my answer into the universe? Okay, great. A lot of people are already putting it in there. Awesome. Awesome. Excellent. So the big things for oxygenation, the 2 things you can fix are PEEP and FiO2. Those are the 2 things that are going to make a difference. In this case, they tell us that the FiO2 is 90% and that the PEEP is 5. So if we think back about the slides that we were talking about with PEEP and FiO2, FiO2 of 90% is incredibly high. As Joe was saying, really anything above 60, you're just, making minimal changes at that point. You really don't go much. I mean, honestly, I've never actually seen 90. So really, it's extremely high, and it's kind of optimized to maximize oxygenation. PEEP, however, is only at 5. And as we saw, you don't really get diminishing returns until you're up around 15 plus. So for that very reason, in this case, the correct answer is to increase the PEEP, as many of you have already accurately pointed out. So that's sort of how I work down this algorithm to get myself to the right answer. And then just looking at the other answers, right? Respiratory rate, tidal volume, already discussed those. Those are about carbon dioxide levels. They don't even talk about that in this question. And then PEEP, of course, the correct answer. IV fluids, red blood cells, has nothing to do with the oxygenation level, right? What this is looking at is a mechanical ventilation issue. Fluids are not going to help this patient. Red blood cells, not related. So don't let those sort of red herrings make you think about, oh, more red blood cells means more oxygen recruitment. Don't even think about it. Think about the basics of that algorithm.
All right, awesome job running through that. And I think that one thing I want to just detail a bit more about what you had said there and emphasize is that you mentioned 60% was a number that we think about a lot with FiO2. We really don't want to go above 60% if we can avoid it because of the risk of oxygen-induced toxicity to the lung. Oxygen is obviously an oxidative agent, and you can actually cause cellular injury due to overproduction of oxidative species in the lung by giving too much oxygen. And so as a result, we're kind of stuck in this situation where we really don't want to give a PEEP that's too high, and we don't want to give an oxygen level that's too high. And so generally speaking, the best way to approach helping a patient that's not saturating very well is to kind of shimmy those two values up. You want a little bit more oxygen, then a little bit more PEEP, then a little bit more oxygen, and just kind of push them up individually. In this case, it seems like they might have dropped the ball on that by jamming this person up to 90% oxygen and then saying, oh, let's fix the PEEP now. It probably should have gone up to 60% FiO2 and then increase the PEEP up to 10 or 15 before pushing the oxygen too high. So FiO2 limit safely is 60%, but if you need to give more than that to oxygenate the patient, then you need to do what you need to do. Good question from a student here about talking about tidal volume. Again, you'll notice that the tidal volume was placed next to the actual body weight of this patient here. Now, unclear whether that's the ideal body weight or not, but one thing I would want to emphasize here is that if we look at this x-ray, as Sana had mentioned, this is a person who's developing ARDS, and they're developing a lung that looks kind of junky, to say the least, a lot of fluid in it. If you imagine, again, a balloon as our example, it's going to be harder to fill a balloon with air if it's already half full with water. And so you would anticipate that you can't really put the same volume of air into a person who has lots of fluid in their alveoli and their lungs. And so one thing you might want to keep in mind about somebody who has pulmonary edema or outright ARDS is that they probably would require a lower tidal volume when you're providing ventilation to them. So we give them low tidal volume ventilation. Not that you need to know these numbers, but as we had mentioned before, the perfect number when you're starting out intubating somebody for tidal volume is 8 mils per kilogram of ideal body weight. If somebody has significant pulmonary edema, you could give them 6 milliliters of air, or tidal volume rather, per kilogram of ideal body weight. You don't need those numbers on the exam. This is really clinical at this point, but it's kind of nice to think about because we have like a preset number that we would go to. This person's kind of in between those two in that case. It's not quite 6 or 8 times 60 to get to 400. So weird choice on their part maybe, but you can kind of step down a little bit as you'd like to, and it depends on what their ideal body weight would be anyway. So takeaway here is we don't want to give too much air to people, and we will potentially recalculate the tidal volume in the ICU when you're working on a rotation with real patients. Probably never going to be asked on the exam though. So again, respiratory rate becomes the major thing we would use to control CO2. All right, so thanks for running through that question with us, Sana. One extra thing to mention here about how we can control the ventilator. There's a whole bunch of different modes that we can use. Volume control, pressure control, SIMV, et cetera, et cetera. Irrelevant for the board exams up to step 2 CK. Can't promise anything about step 3, but up to step 2 CK, you will never, ever need to know anything about the ventilator modes. You need to know about how to control oxygen and CO2, but you don't need to know what pressure control or volume control or any of these things are. So you can safely ignore these when you're learning about how to work mechanical ventilators. So don't stress about this stuff, even if they include it in the question stem or a vignette, which they may. Don't need to know anything about it. So ignore that for now when you're learning about how to control mechanical ventilators. Come back to it if you're going to be working in the ICU for a rotation or moving on into residency. At that point, it does become important. All right. So, Sana, you want to lead us through yet another question here?
Yes. So speaking of junky chest x-rays. So 34-year-old woman brought to the hospital with high-grade fever, shaking chills, productive cough, shortness of breath. Okay, so I'm already very concerned about some sort of septic picture, maybe pneumonia, who knows. has had 2 hospital admissions for alcohol withdrawal seizures in the past year, but continues to drink alcohol every day. Okay, so now I'm thinking certainly about withdrawal seizures, potential complications of alcohol withdrawal, etc. Patient has no other medical problems, no medications. She has a temperature of 103.5, blood pressure of 100 over 70, pulse is 110, respirations are at 20. Okay, so tachycardic, febrile, blood pressure is maybe a touch soft, but 34 could be, low normal, and breathing fast. Skin and mucous membranes are dry, and then physical exam showing crackles and bronchial breath sounds in the right lower lung field. Cardiac exam is unremarkable. Chest X-ray shows right lower lobe consolidation. 12 hours later, she got the IV antibiotics. 12 hours later, she has severe shortness of breath. Pulse ox is now 80 on 100% non-rebreather. Decision is made to intubate, and this is the chest X-ray after. So based on this initial story that I'm getting, right, she came in with what sounds like a pretty classic pneumonia, right? She had a right lower lung infiltrate. She had fevers, chills, shortness of breath. She had a clear consolidation. She had classic pneumonia picture. But then after getting treated with antibiotics and after having some time away from alcohol as well, she's having severe shortness of breath with a very, I would submit, and you can sort of consider bilateral diffuse infiltrate, almost complete whiteout of bilateral lungs, right? So you can really see the central predominant opacities are completely obscuring bilateral lung fields. And then we see an ABG showing PaO2 of 60 on 100% oxygen, right? So the PaO2, as we discussed, anything under 70, you should be thinking, okay, this needs to be brought up. So here we're at the level of 60, so very low. So which of the following best explains the patient's symptoms? So a lot of people are throwing in their answers. Let me see what we got. Okay, great. Yeah. Actually, we've had a fair mix of answers here. So what I'll say is, looking at this here, this deficit, again, diffuse bilateral fluffy infiltrates. So that should already be priming you based on my wording alone for a certain answer. But the big thing is that in this case, this patient is a perfect setup for ARDS based on my wording A, but she's the perfect setup because of this pneumonia, poor substrate, this history of alcohol seizures and withdrawal seizures particularly. She is in a very primed position to have a significant inflammatory response. And we're going to talk about the inflammatory response that's involved in ARDS and why that causes this picture. But she's just recently started this treatment, this very acute, sudden worsening is a classic picture for ARDS. And so again, these other options, diffuse alveolar hemorrhage, really no reason that she would have alveolar hemorrhage, right? There's nothing in her history to suggest any sort of hemorrhagic process, or she's not, saying that she's vomiting blood or anything. Hospital-acquired pneumonia, she's only been there for 12 hours, unlikely. Fluid overload, again, too young, too acute onset, no real, risk factors for that. And pulmonary thromboembolism, again, chest X-ray doesn't really fit that picture. Sure, she could, be somewhat immobile, but 12 hours of immobility is not really going to give you a PE, especially in an otherwise young and healthy person without medication. So key answer here is ARDS. And so speaking of ARDS, oh yeah, sorry, I'm going to go to the inflammation.
Sorry, I just want to jump in really quickly. A few
Yeah,
students had answered the diffuse alveolar hemorrhage. I just want to jump in with like a general USMLE-style question tip here. If this person had diffuse alveolar hemorrhage, which was the second most popular answer behind ARDS that you guys were submitting to us, and this much blood is in their lungs, it would be criminally incompetent for them to not tell us that there's blood coming out of this person. Like, they would have to be coughing up blood if that were the case. And I know that part of us always thinks when we see these questions, yeah, but what if they're hiding that? So like, I have to figure this out based on other means. They're not going to avoid giving you, it's such an obvious clinical indicator if it would exist. So if somebody comes in with shingles and they say you look at their skin and you don't see anything, the answer can't be shingles anymore. Like they're not going to hide things that are blatantly and visually obvious to you. And a person who had a lung full of blood would be coughing up blood. So Sana ran through that really quick. Like, well, she's not coughing up blood. That would be really important that they would have to be coughing up blood if they had that much damage going on. So sorry, Sana, I just want to jump in there and say just a general tip. If there's no like clear evidence of like a very obvious finding that should be associated with one of these pathologies in the answer choices, we can fairly safely rule them out. We don't have to believe that the test is tricking or fooling us in many cases. As much as I know you guys want to think that the exam is trying to fool you, it's usually not going to hide that kind of information from you. But anyway, Sana, please continue to talk about ARDS and how it happens.
Yeah, absolutely. So I think the important thing to understand about ARDS physiology is that knowing the underlying sort of process is really helpful in understanding why it manifests as it does and what the findings are, A, on exam, and B, in terms of how they clinically present. So the big thing is this is an inflammatory process throughout the lungs. And the main site of injury, the main part of the lung that's getting damaged is at the edges of those alveoli where they're interacting with the capillary membranes. So you're seeing any sort of insults, whether that be, some sort of trauma, as in the case of our motor vehicle accident patient, or just a patient who has pneumonia and is like very full appearing. These patients can have significant inflammatory response to these infectious or inflammatory processes that are causing them to react. And so this membrane becomes very, very permeable. And then you have fluid that fills up the alveoli. So you have these normally very, open, air-filled black alveoli on chest x-rays now filled with fluid. So all of those sort of grapes on the vine are now filled with fluid, which means that you have these sort of fluffy. That's why they're described as the fluffy appearance, because again, reticular opacities, interstitial opacities are linear and branching and in the pattern of vessels, right? So that's a pulmonary edema issue. This is alveolar edema, and they're in the actual alveoli, and which is why you see the fluffy infiltrates that are more diffuse and more ill-defined, and not these sort of like linear branching patterns. This is when you see that fluffiness of the infiltrates. And that's because of that damage to that membrane, which causes all of the fluid to seep into the alveoli. And of course, just to briefly talk about what that does to the actual lung and your ability to breathe, if you have a portion of the lung that's not being used, in spite of the fact that blood is being passed through, that's when we think about dead space, right? So a shunt, or excuse me, that's when you think about a shunt. When you're thinking of the fact that blood is flowing through, blood is able to pass, but there's no air to exchange, then we have a shunt, right? However, when you have a clot and no blood is able to pass to exchange with the air that's waiting to exchange with it, that's when we think about dead space. So in this case, there's no air to be exchanged, so we're thinking about a shunt. And that's the classic thing in ARDS. Anything additional on that, Joe?
I'll just emphasize what you had said about the shunt being really important here. So this is something that I had a really hard time kind of understanding until I was actually teaching other students, and then it finally kind of clicked for me. So I want to detail this a little bit more in terms of what a shunt means. I want everybody to think about what a cardiac shunt would mean. If I were to say that somebody had a right to left shunt in their heart, meaning that they have some kind of Eisenmenger syndrome where they have a VSD and then they switch that shunt around, so now they're going from right to left. Blood will be entering into their right heart and then passing into their left ventricle and then out the aorta without any attempt to go to the lungs whatsoever. There will be some blood that's never going to attempt to go to the lungs in a right to left shunt in the heart. That's, of course, going to cause cyanosis in the patient. And no matter what you do, no matter how much oxygen you give to that person, you're not going to improve their oxygen saturation above a certain point because some of the blood's never going to the lungs anyway. And so a shunt is a situation where you have blood moving from one side of the circulation to the other. And specifically, a right to left shunt is when blood goes from the deoxygenated side to the oxygenated side, and you can't fix it by giving oxygen to the person. Now, bouncing off of what Sana had said before, if the lungs are totally full of fluid and you're a red blood cell that travels to one of the alveoli that are completely underwater, you as that red blood cell are not getting any oxygen from that alveolus. You're passing through to the pulmonary veins, to the left atrium, to the left ventricle. You've now made the complete journey from the right heart over to the left heart and never received any oxygen exchange whatsoever. No matter how much oxygen you put into the patient, if the alveolus is totally underwater and no gas is reaching that alveolus, then you're not going to provide any oxygen to that red blood cell.
Right.
What that means then is there's no difference to whether you went through the lungs that have ARDS or you went through the ventricular septal defect. It's still a right to left shunt either way. Blood got into the left heart from the right side of circulation without gas exchange happening whatsoever. So in ARDS, we define this as a physiological shunt, where the blood has passed from right to left through the correct anatomical pathway, but with the same kind of mechanism and problem as though they had like an Eisenmenger syndrome. And so now we start to hit upon the real big problem with ARDS, which is that when they have this pulmonary whiteout, when they have really junky lungs, like Sana was mentioning with these fluffy infiltrates all over the place, and all of their alveoli are starting to go completely underwater, and they're starting to deoxygenate because they can't get oxygen through there, all you can really do is try to give them more FiO2 and maybe some more PEEP. But FiO2 isn't going to help you if we have a physiological shunt. One of the only ways a patient can develop resistance to more FiO2 is by having a physiologic shunt. And so as a result, ARDS is super dangerous because if they have this, you can't oxygenate them no matter what. So I won't puzzle you guys too much, but usually I ask you, well, what would you do for ARDS? The answer is give oxygen and pray, basically. What we're going to find here is that the mortality rate for ARDS is quite bad. And there's really not too much that we can do about that. So when somebody develops ARDS due to sepsis, pancreatitis, trauma, respiratory virus spread, you can put them on a ventilator, but in many cases they will not survive, which is really rough to deal with. And importantly, there's two ways to diagnose ARDS. On the one hand, we have the clinical diagnosis, somebody who has real hard time breathing, we intubate them and we see their lungs turn into this whiteout. That's ARDS pretty much every single time. The other way you can diagnose ARDS, though, if you want to be super fancy about it, is you can compare the oxygen in their arteries and their fraction of inspired oxygen. This gets a little tricky, but this is called the Carrico index. And the basic idea is this. In Sana and I right now, we have a PaO2 value of somewhere around 100, and we have an FiO2 value of somewhere around probably 21%, which is room air. The ratio between these two numbers is about 500. Imagine, however, you have a patient with ARDS, and by definition, they've got a bad PaO2. Let's say they're at 60 for their PaO2, and I'm giving them 60% oxygen, but they haven't improved their PaO2 because they have ARDS. Now, because they have ARDS and oxygen isn't working, the ratio between PaO2 and FiO2 is lower than it should be. If you divide PaO2 by FiO2 and it comes out to less than 300, you have ARDS by definition. This is the mathematical definition that we can use for ARDS. So if we take a look back at some old material, if we go back for those of you who have already taken step one and take a look at the first aid entry for ARDS in first aid for step one, you might be surprised to find, I know it's small here, that they actually had this ratio in first aid for step one all along. This has always been the definition of ARDS, is that you give oxygen and it doesn't work. And so you can easily diagnose ARDS on the exam if they give you the FiO2 and the PaO2. And if you think about that a little bit, how could they ever not give you the PaO2 and the FiO2 if they're giving you a question about ARDS? So basically every ARDS diagnostic question becomes instantaneously solvable because they have to give you these numbers, and the ratio is always less than 300 when we have ARDS. Just really quickly, I want to point out the management for ARDS again, mechanical ventilation, probably giving them as much PEEP as you can, and maybe even giving them a low tidal volume because ARDS has a lot of fluid in the lungs, which is going to lower the ability for us to expand their lungs. We're going to need a lower tidal volume as a result. So let's culminate all of this together and take a look at the same question that we just looked at. This vignette is exactly the same, just saw it. And one thing I want to emphasize here is that if this person has a pulse oximetry of 80% on a 100% non-rebreather mask in the first place. That means that their PaO2 is probably somewhere around below 60, despite the fact that they're getting 100% oxygen. And that probably means that we have ARDS. We could figure it out based on the math. We actually gave you the PaO2 value and the FiO2 value in the first version of this question, and we could calculate it that way. So let's bring everything together and look at a different question about this same ARDS patient. Right before we intubate them, they want to know which of the following things would be true here. So take a moment, look at these as our summative question, and try to decide which of these best describes what is happening in ARDS right before we intubate them. You guys can go ahead and try to give some answers as you read through these. I know this is a tough one. It's a long list of answers.
Nice, a couple of people.
All right, you guys are doing good. These are good answers. So a lot of people have picked up that what we're finding here is that somebody who has a lot of fluid in their lungs has very non-stretchy lungs, which means that we have poor lung compliance. And remember, this is what we were saying before, that poor lung compliance would mean that we're going to have the need for a lower tidal volume. Again, they're probably not going to ask that, but they could ask us about lung compliance on the exam. They're not going to ask us what we would do here, like lowering tidal volume. That's a little too complicated. But we do recognize that somebody who's got this big pulmonary whiteout and lots of fluid building up their lungs likely doesn't have very stretchy lungs. Going through the other answer choices here, these are some pretty tricky answer choices. The ratio of PaO2 to FiO2 goes down in ARDS, not up. And so that's the kind of trick answer that they're supplying here. And the AA gradient in this case, we're inhaling 100% oxygen. So our alveolar oxygen, to the extent that it exists, is very high, where our arterial oxygen is very low. The gap becomes quite significant in ARDS. And if you have this much junking up of the lungs, you're likely going to experience a lot of hypoxic vasoconstriction for the arteries going into the lungs, which means our pulmonary artery pressure will be experiencing some back pressure. We will have congestion there that occurs. All right. Anything to add to that one, Sana?
No, I think that was perfect.
All right, great. So we are now going to pivot into taking any questions you guys still have about anything we talked about. So if you guys have any questions, and I see there's a couple still coming in here, go ahead and fire them away at us here. While you guys are thinking of some question to ask us, I'll just kind of jump into who Med School Tutors is and give you our background a little bit more before we wrap up here. So once again, Med School Tutors is primarily a one-to-one tutoring company that pairs physicians, medical students like Sana and myself with students like you as you prepare for anything in medical school. That means getting into medical school in the first place, if you happen to be a pre-med who's watching this right now, but it also means doing anything from coursework exams in MS1, MS2, preparing for step 1, shelf exams, step 2 CK, applying to residency, step 3, and then even beyond that. One thing that's really nice about the way that Med School Tutors works is that we really do form a pretty tight relationship with students that we work with. And as a result, we tend to work longitudinally with people, even beyond finishing with the exams that they signed up for with us. And so as a result, I still work with students that I had met when they were MS1s, now that they're like MS3s and MS4s and even matching at this point. And that doesn't necessarily mean we always continue to work with them in individual sessions, but I still get updates from people several years later as they move on to residency and things like that, kind of sending me updates and occasionally asking me questions about how to prepare for shelf exams and stuff like that. The idea is if you're looking for somebody who can kind of guide you through medical school or any aspect of medical education, hopefully we can pair you with somebody that's able to do that. We like to form longitudinal relationships, and we treat this more as a mentorship for people who are involved with medicine rather than necessarily isolated to just tutoring factoids and things along those lines. One of the main things that we do is we work over camera like this with individual students, although we like to do these webinars from time to time. Most of our work is one-to-one. So if you're interested in working individually with a tutor like Sana or myself, please feel free to reach out. We've got our communication information at the bottom of this slide, and I'll bring it up bigger in just a moment here. Also, just want to point out, if there's just a small short-term thing you guys are trying to work on, like maybe just like planning out your step 2 CK preparation or something along those lines, or looking just for a little bit of advice in terms of how to tune up your ERAS application, feel free to reach out. We're happy to do short-term work with you guys too. So if you guys are looking for somebody to kind of help guide you through the process because it's pretty stressful, please feel free to reach out to med school tutors. For now, we're going to go ahead and answer any questions that you guys have. It looks like we got a couple queued up here. Sana, do you see any that you want to start out with?
Yeah, we've gotten a few just to sort of clarify some of the dead space versus shunting. And so just to very briefly touch upon that. So in ARDS, as we described, shunting is the primary sort of method of damage to the lungs. And so the reason for that is what dead space is. So first I'll go through what dead space is. So normally you have the alveolus, which has a certain amount of air in it available for exchange. And you have the capillary membrane, which allows exchange of oxygen, or allows rather oxygen and CO2 to be transferred across those membranes for that exchange to take place so that you can have oxygenated blood. And in the case of dead space, so when you think of dead space, I want you to basically think of the fact that there is air there waiting to be exchanged. However, there is nothing coming through as far as oxygen or CO2 via CO2 via red blood cells, right? So that would be, for example, a pulmonary embolism, right? A pulmonary embolism leads to a clot in the vasculature, and there is no red blood cell flow into that alveolus. And because there's no red blood cells, there's no exchange of oxygen and carbon dioxide. That is a PE sort of physiology. So the problem is usually in the vasculature case. You have oxygen that is available, but nothing's getting through. In the case of shunting, what we're talking about there is that the blood is getting shunted, as Joe described, right? The blood is going from one place to another without having any change in the oxygenation levels. It's starting from the right circulation, going to the left circulation, no change in the oxygen levels. And that occurs when there is not oxygen, or there is not air available for whatever reason. For example, ARDS, where the alveoli are filled with fluid, as opposed to, the atmospheric air that would allow it to exchange. So the blood is flowing, no problems. So when you're thinking about shunts, I want you to think more about a problem with the airways. And when you're thinking of dead space, think more about the problems with the vasculature. Is that a fair sort of breakdown, Joe, in terms of how to think about dead space versus shunting?
Yeah, I think you nailed it. It's one of the more frustrating things to try to figure out like the difference between those two. In all honesty, the way that I kind of think about them is as being like the perfect examples of VQ mismatches. So they're both technically VQ mismatches. It's just that one of them is a V of 0 and the other is a Q of 0. So no perfusion would mean that we have dead space, and no ventilation means that we have a shunt. And so the only thing I would add into that is that a VQ mismatch technically encompasses those two things. So it gets a little complicated with those tables that they give you. Cool. All right. So one question I'm seeing a couple of students ask is about peak airway pressure, or alternatively plateau pressures, which are two terms that technically do show up on here. So I'm gonna do my best to answer this as coherently as I can here. If you ever see a diagram about mechanical ventilation that looks like this, which basically kind of looks like depolarization curve for my site, I now realize as I'm drawing it out. What they're describing here is what's called a plateau pressure. The idea is, what if you pushed a volume of air into a person and then you closed the machine? You made it so you trapped air, like you're holding the balloon full of air. If you did that, and then you measured the pressure inside the balloon, you have measured the volume that you put into the balloon, and then you measured the pressure generated by putting that volume in there. So what I'm getting at here is, if you were to blow air into a balloon, hold the balloon full, and measure its pressure, you've now measured a change in volume and a change in pressure exerted by filling the balloon up. By definition, a change in volume and a change in pressure is the measurement of compliance. So if you ever see anything that kind of looks like a depolarization curve like this with regard to mechanical ventilation, what they're doing is saying, I gave this much air, I measured the pressure after I gave that much air to be this. Now that I've measured the volume of the pressure, what have I actually assessed? You've measured compliance. You might want to measure the compliance in a patient with, say, pulmonary edema or ARDS, because you can determine whether or not their lung compliance is worsening acutely due to the fluid building up in there. And that can give you a reason to change the tidal volume, which we've mentioned quite a bit, but remember, that's not going to be a question they'll ask you on the exam to change the tidal volume, but they might ask you about the things surrounding why you would change it, which would be compliance changes, which are pretty common when people have fluid building up their lungs and pulmonary edema. To answer a follow-up question, students asking, well, if you have more fluid in the lungs, would that not increase compliance? No, if we have more fluid in the lungs, that means there is less space for air to enter. When we say volume in the lungs, we're talking about the volume of air we can put in there. And so if your lungs are half full with fluid already, you obviously can't put as much air in as you would have wanted to. So you push the air in with the same pressure that you would have before. The pressure hasn't changed, but the volume has decreased. And so if we're looking at our compliance equation, which is the change in volume divided by the change in pressure, what we're going to find is that if you have less volume, but an equal amount of pressure, that's less compliance overall. So fluid building up in the lungs always is going to be a lower compliance value. Any other questions you're seeing, Sana?
No, I actually think we've hit most of them.
Cool, excellent.
Yeah, I think that's most of it.
Glad to see that. All right, Sana, any closing words as we wrap up for tonight?
The big thing is really a lot of these questions are very intimidating when you first look at them, but hopefully we've given you a framework to sort of walk through how to approach them. I think if you use our algorithm, if you use our sort of thought process in terms of what do I need to fix and how can I actually fix that thing, it makes it much more manageable. And these questions are definitely scarier than they actually are when you first see them. So good luck, and I wish you all the best.
Same. Thank you very much, everybody, for showing up and being so interactive tonight. We really appreciate you guys answering our questions and playing along. It definitely makes it easier for us to teach you guys this stuff. So we wish you the best of luck as you prepare for your exams, and we'll look forward to seeing you hopefully in our next webinar.